Well, good morning, Stephen. Thank you for that introduction. I hope I don't experience too much of healthcare. Nothing against Canada with the trip to Whistler. We'll try to do that in other ways. I want to thank Dr. Cochran and the Planning Committee for the chance to be here and send my greetings to all of you and congratulations from Utah and Intermountain Healthcare. I think there is a special relationship between our organization, our state, and the ministry and the province here in British Columbia. Dr. Brent James, who serves as my boss and our director, also sends his greetings and his congratulations. He has not only an affinity, I think, for the province, but a special relationship with a few in this room, and he asked me to convey his welcome and thank you. Well, I'm currently driving a 2002 Honda Odyssey that uses a little bit of duct tape to affix part of the bumper to the car. So you can probably tell I don't really have any disclosures to make this morning. I want to say we live in one of the grandest times of healthcare there has ever been. About a summer and a half ago, I was working in my emergency department at Intermountain Medical Center in Salt Lake City, Utah. And we got a call from one of our affiliated hospitals, Park City Hospital, new hospital that opened in about 2008 to serve the ski community of Park City, and a terrific addition to our organization. The call was about a 56-year-old female who had been with her family at Rockport Reservoir, a boating area about 40 minutes from Salt Lake City. She turned out to be a nurse at Intermountain Medical Center, and a few years prior had been afflicted by a DVT and pulmonary embolism caused by a genetic abnormality, factor V Leiden. And so she was on Coumadin, and the Coumadin therapy, the warfarin therapy, was being tailored based on a genetic profile that she had as a fast metabolizer of warfarin. Some of you may have heard of that technology. Well, she was at Rockport, standing on the back of the boat, helping one of her children into the boat when she slipped and fell, striking her left flank on the side of the boat and into the water. Immediately, it's quite apparent that this was more than just a simple fall. She was lightheaded, she was pale, she had terrific pain. The family was able to pull her into the boat using their cell phones to call 911 as they rallied into shore. The ambulance met them there, took her very quickly to Park City Medical Center, which is about a 10-minute ride away. And as she came in the door, her heart rate was about 130. She was having difficulty breathing. Her blood pressure was 60 systolic and looked pale. The emergency physician there had the wherewithal to recognize, put two and two together, and to recognize what was likely happening, and called us immediately at the trauma center down in Murray. And we were able to watch in real time her CAT scan come up. Many people in here may not be familiar with reading CT scans. The image on your left is a cross-section. Her spleen is this organ. I'll point to it over here. This organ here, blood behind the spleen, and these white spots are active bleeding. We saw this in real time. A helicopter was dispatched to pick her up. She was brought to us, and she immediately went to the operating room. A laparotomy was performed. The spleen was removed. This is, of course, while we reversed her coagulopathy that was due to warfarin with FFP and PCC, and she lived to work another day. We live in an absolute age of miracles. Think of what has happened in our lifetime. The human genome, fully available. As in this case, in 2000, heart disease, they set the goal to reduce by 20% deaths due to ischemic heart disease by the year 2008. We shattered through that record, 40% down in a decade. The miracle of stem cell research built on bone marrow transplantation, the minimally invasive surgical techniques that we take for granted every day, laparoscopic procedures, remarkable. Targeted drug therapies for cancer on the molecular, the receptor, and the hormonal level, a terrific advancement, turning some cancers into chronic disease, in the same way HIV and AIDS into a chronic disease using the highly active antiretroviral therapy. And even things as simple as electronic health records, to have those tools at our fingertips, that knowledge instantaneously is a miracle. And yet, these miracles come at a price. This is a graphic, representing the Western countries with respect to healthcare expenditures per person. In the United States, we crossed 8,000 easily. Last year, I think in Canada, the last I saw by OECD data, was $4,500 a year. It eats up 18% of our GDP, I think about 12% of yours. The miracles are bankrupting our country, and they'll bankrupt your country. And if they don't bankrupt the country, they'll certainly give us Faustian choices about whether to fund healthcare or K through 12 education in the very short future. Healthcare is an anomaly as to how it performs in a free market. Does anybody remember the cost of a barrel of oil in 1972? We're undergoing an energy boom in the United States and in Canada. It was $2, $2 a barrel, $10 in 78, and we know in 2012 hovering around $91, $95. How much has that barrel of oil changed as a product against those decades? Not at all. The market forces traditionally apply to products like oil and not so much to healthcare. Last night I was watching the news while on the treadmill, and they had a story at Cleveland Clinic about an embryo cam. Did anybody see that? So in real time at the sub-millimeter level for in vitro fertilization, researchers and fertility specialists can watch the growth of an embryo over time. That didn't exist in 1972, and no wonder it costs more as our population ages, as technology change, and as more people want access to our miracles. No wonder we're seeing inflation in healthcare at a level that far exceeds traditional markets. Now, this applies principally to the United States, but I think it applies to Canada as well. Alan Einthoven, a researcher from Stanford University, said the United States does not have decades to wait for healthcare reform. In 2009, we spent about $1.15 trillion, that's an immense number, of our federal budget on healthcare, and healthcare expenditures are growing faster than the gross domestic product. It will, as I said, bankrupt the nation. We'd solve this problem by about an increase in our tax rate of 134%, but for your economy or our economy, that's clearly not sustainable. And so the next step in our journey is healthcare reform, delivery and payment reform, as opposed to our health insurance reform. I hope, will never, I don't think we will be for a long time, a single payer system like Canada, but I think our recent political efforts, such as they are putting us in a place where we're truly now working on similar things together. Now, I would say this about our journey and your journey in healthcare reform: there's always trade-offs. It's the balance between equity, quality, and cost. Those concepts are those around which we make choices, and you can't just transplant healthcare systems one to another. We have a lot to learn from Canada, and perhaps Canada has some things to learn from the United States. I'm particularly impressed by your healthcare law. I think was passed in 2 stages in 57 and 66. 14 pages, I think, in total, compared to our ACA, which was 906 pages, and toward which one of our leaders famously said, "Oh, don't worry about reading it. Once you pass it, you'll like what's in it." Perhaps the wrong way to go about health reform. And in the United States, and I think this is probably true in Canada as well, administrative costs and complexity are relatively high. We need clinical leadership from all of us in the room to avoid the micromanagement strategies that predict things like value-based purchasing in the United States and other intermediate quality measures. Well, I want to go back a little bit. It was about a century ago, almost exactly, that the era of modern medicine started. Prior to the 1900s, medical training was really barely that. It was a craft, just like any other craft, an apprenticeship, just like you saw in any other way. Medical training was at the most 2 years, sometimes only 6 months, and not even a high school diploma was required. The AMA, working through the Carnegie Foundation, hired a gentleman named Abner Flexner to do a report and issue new standards for clinical education in medicine. And it was a result of that about half of all medical schools closed down. We developed a 2-year preclinical curriculum and a 2-year in-hospital curriculum. And it was from that the organization, the modern organization of hospitals with administration on one side and clinical practice on the other side, began a new internal organization. It allowed us to take a structure and shift from the humoral theory of disease to the germ theory of disease. And if there is a moment in time that's described as the change in healthcare, it's perhaps 1912. Harvard researcher Dr. Henderson wrote this about that time: "For the first time in human history, a random patient with a random disease, consulting a doctor chosen at random, stands a better than a 50-50 chance of benefiting from the encounter. And think about that. The humoral theory of disease, before that we had really two therapies. We had bloodletting and we had purgatives. In fact, the father of our own country, George Washington, on December 14th, 1799, was riding around his property after his retirement, collecting observations on the weather, 30 degrees Mercury, light snow falling 3 inches, and marking trees that he would have to cut down in the springtime. He came home wet, and the next morning felt unwell. Over the course of the next couple of days, 4 individual physicians were called to his bedside, and each recommended bleeding as the therapy. By the second day, by December 14th, he had been bled about 5 units of blood, and he died that night. In fact, hospitals at that time, were set up where people went to die. And more than that, it's where poor people went to die. If you were like George Washington, if you had means, the physicians came to you. And so it was a remarkable change in this. And William Osler, a Canadian, wrote this about that time. He said, speaking at his retirement, near his retirement, after his retirement at a Phipps clinic, and he's speaking of his career, "I'm sorry for you young men," and I'll add, "women of this generation. You will do great things, you will have great victories, and standing on our shoulders, you will see far. But you can never have our sensations. To have lived through a revolution, to have seen the birth of a new science, a new dispensation of health, reorganize medical schools, remodel hospitals, a new outlook indeed for humanity is not given to every generation." It truly was impressive. And from that, this is the best the world has ever seen. Your healthcare, my healthcare, is the best the world's ever seen. Life expectancy, think about this, from 1900 to the present time has increased from 49 years to almost 81 years by Canadian demographics. Remarkable. We mentioned the deaths from heart disease and from stroke, similar advancements. An amazing production due to this system that began to be set up about a century ago. And it leads to the great equation that health equals medical care, and traditionally medical care equals access to care. But the point of our being here today is indeed that the great equation is wrong. Lest we get too comfortable with our miracles, too proud in our miracles, I would add this: that behavior really is 40% of that benefit, from 49 years to 80 years. Tobacco use, alcohol use, especially as it relates to violent crime and accidents, obesity, sexually transmitted disease, and unwed teenage pregnancies are the biggest contributors to those increases in life expectancy. Genetics, how smart you were in choosing your parents, is the second factor. And then public health, clean water, clean air, food inspection makes the next biggest contribution. And on average, since 1960, really the era of hospital contribution, medical contribution towards that increase in life expectancy, about 10%. So what do we get for all that we spend, recognizing that much of it, 90% of it, might be out of our control? Dr. Deming has played an important role in Intermountain Healthcare and in quality improvement theory as it relates to healthcare over the years, and he said famously that AIM defines the system. So let's look for a moment at the aims of a healthcare system. Well, there's total health, how well and how long we live, but yet we've seen that might be 10% of ours. High touch, that unique relationship between a clinician of any type of training and the patient is another potential aim, that relationship with a trusted advisor. And this is a beautiful statement that talks about that purpose written in a book called In Defense of the Art of Medicine. He says, "A man stricken with disease today is assaulted by the same fears and finds himself searching for the same helping hand as his ancestors did 5,000 or 10,000 years ago. He has been told about the clever tools of modern medicine, and somewhat vaguely he expects that by and by he will profit by them. But in his hour of trial, his desperate want is for someone who is personally committed to him, who has taken up his cause, who is willing to go to trouble for him." A beautiful statement about that relationship of medicine. And think about the role that medicine has played in societies for millennia. Even in pre-literate societies, we find artifacts that demonstrate the value of this relationship. And yet, if you follow the money, that may not be where we place our emphasis. So perhaps total health is not the aim. Perhaps high touch is not the aim. It may be, indeed, in rescue care. Rescue care is a theory advanced by social scientists, kind of promulgated beginning about 1986. It's the imperative people feel to rescue identifiable individuals facing suffering or death. It's the idea that adult humans will put any number of lives or money at risk to save someone. Think of this as baby Jessica down the well, 18 months old. In 1987, she spent 58 hours, where we literally moved heaven and earth to find ways to get her out of that well. In Utah, we too, like your region, have an energy sector. In 2007, at a mine called Crandall Canyon in the eastern central part of the state, there was a mine collapse and 6 miners perished. We did the same thing. We sent in, as those names and the pictures and those families were broadcast on the news, we sent untold more men in to that mine, and 3 more died 10 days later with a subsequent collapse. It translates beyond adults. It translates to animals. We're all familiar, especially here, probably with the rescues of whales trapped in ice, a dog on the abandoned boat in Hawaii. This is the rule of rescue. And on a personal level, it reads like this, from Ian Morrison, who's the president for the Institute for the Future in California. I grew up in Glasgow, Scotland, where death was seen as imminent. I trained in Canada, where death was seen as inevitable. I now live and work in California, where death is seen as optional. No wonder we have trouble with the miracles. No wonder we have trouble accessing the miracles. And so we get to the point where we need to investigate where the gaps are and where we need to bridge. So I want to spend just a moment talking about those concepts. There's a statement variously attributed that says, "Whom the gods will destroy, they will first make proud." And indeed, we have a lot to be proud of in health care. But this structure that was built up started in 1912 or the early 1900s with respect to facilities, hospitals, as the source of rescue care, perhaps while a solution then and decades ago is now part of the problem. Our success, in other words, in hospital-based rescue care cannot be perhaps our ongoing solution. So where do we fall short of our theoretic potential? What makes it harder to get to the miracles? There's 4 things basically which lead to the 5th point on this slide of the huge amount of waste and spiraling prices. And that is the well-documented and massive variation in healthcare that exists. The variation is so striking that you could not even begin to postulate that all people are receiving good care wherever they are. This science was begun by Jack Winberg, Dr. Jack Winberg in the Dartmouth Institute, and this idea of geographically based variation research is something that's quite familiar to us all now. There are high rates of inappropriate care where the risk of a particular treatment, dialysis in the 87-year-old, vastly exceeds any expected benefit. We know from the Institute of Medicine reports about the unacceptable rates of preventable injury and death, somewhere between 50 and 100,000 Americans dying each year from medical mistakes, and some of those indeed are the elderly in the last days of life where the mistakes hasten the death. But many, about a third, are in young people. The lady at my institution who had ovarian cancer was diagnosed with ovarian cancer and went in for surgery to stage that cancer. Upon opening, the surgeon found widespread cancer, tightly adherent in the pelvis, and where on a mostly normal day, he would have closed and pursued other therapies. On that day, he decided to explore anti-bulk. And it wasn't long before the large veins of the pelvis began to bleed. The bleeding could not be stopped, and she died on the table after about 80 units of attempted transfusion. Now, with advanced cancer in that degree, she may have died anyway, certainly would have died anyway in 6 months, but how much is that 6 months worth in that particular patient over that particular time? There's a striking ability to do what we know works. I'll spend some time on that. That's quality waste, that's inefficiency waste, and it leads to pricing failures as a representation of these process failures. Now, waste in healthcare is difficult. But it is essentially where our charge in part lies over the next 5 years to 10 years. The first instance quoted is from a RAND study over 12 metropolitan centers, essentially saying that we got it right about half of the time, a little more than half of the time. This is aspirin and MI, this is beta blockers post-MI, traditional therapies toward which there is good evidence. And there's inefficiency waste, where about 50% of all that we do in healthcare just is waste. And until we identify and root this out, it'll be quite challenging. For example, I was part of the study. The study came out of Intermountain Healthcare. I was unknowingly part of the study, I should say. I was working in the emergency department, and the researcher came and observed me for a shift, categorizing the things that I did. Amazed to find that only 30% of the time was I involved in direct patient care. The rest of my day, this 10-hour shift, was built around clarifying, correcting errors, fixing mistakes, asking for additional information, searching out information. A remarkable loss of value in the healthcare system. So to improve quality, we need to eliminate inappropriate variation and document continuous improvement or outcomes over time. Okay. The hospital system, as it grew up in 1912, also separated management from clinical care. It was the idea that we would set up administrators on one side and physicians on the other, and the two wouldn't necessarily communicate. You don't bug me, and I won't bug you. You provide me a place to take care of my patients. My patients are unique to me and my practice, and I don't need that help. That conversation occurred between clinicians, as you know as well. Over the years, this idea of a profession grew into this idea of a craft-based practice, with individual physicians working alone, handcrafted, customized solutions for each patient based on this core ethical commitment to the patient and this vast personal knowledge that could only be gained through the experience that I or you had developed. This is frankly a perversion of what is supposed to be professional autonomy. It became individualized to personal autonomy somehow, and that's where we need to move away from. The idea of the craft of medicine, in other words, is that idea of an individual physician that places her patient's healthcare needs before any other goal, and that drawing on their extensive experience can craft a unique diagnostic and therapeutic regimen customized for that particular patient. And medicine's promise has been, slightly falsely so, that that outcome will produce the best possible result for each patient. And therefore, quality, what we have described as quality, really arises from personal competence. My heroic individualism, this is the house on our television show, who has to break the rules to succeed for their patient. And errors represent my own professional incompetence. Interestingly, this is where the medical malpractice system was born. You remember from Dr. Lamb's case number 2, I believe it was yesterday, with the irate parent, where that became about him. And it wasn't about Dr. Lamb. It was about the system setting him up and the patient up for this difficult interaction. But when we follow traditional quality improvement, it becomes about the personal. It becomes about the individual. And that's where we need to run from. So we're looking to build a system where instead of personal autonomy, if we only had true professional autonomy and accountability, then we could exceed. Anything other than that is mere license. And when you think about medicine and what we're trying to do here, we need to create a system that documents the best care at the lowest necessary cost. It learns from every case in a rapid iteration of the scientific method, creates a lifelong residency for all of us while we're in our practice with organizational commitment to new knowledge, blending that knowledge into workflows, and pushing it out to all who need it. That truly means transparency, where anytime a clinician says, in my experience, they really mean in our collective measured experience. That's the goal that we need to shoot for. It's the way to address the innate clinical complexity that exists. It produces better outcome for our patients, it eliminates waste, reduces cost, and increases the available resources for us all and puts us back in control of the healing professions and care delivery, rather than the micromanagement that so often comes from external sources. And it truly turns out to be the foundation for sharing useful data, whether it's electronic or paper-based. Now we'll spend a little time looking back at quality improvement theory. This is a picture of Frederick Taylor. He was a university-trained engineer, and he was hired by Henry Ford to to run the Model T factory in Detroit. When you think back to manufacturing in that time, along with the change in hospitals, this was craft-style production across almost every industry. A mentor and apprentice working to build one table at a time, one chair at a time, and even automobiles, which had been introduced in France some decades before that, were made craft-style production. They were therefore a tool, a commodity, for only the very wealthy. And Henry Ford's bright idea was to make these using mass assembly production. And so we brought in Frederick Taylor to set that up based on time and motion studies. And on the one side of the equation was engineers who did all the thinking, and the other side, uneducated workers who did the work. Taylor was famous for firing workers for even speaking on the assembly line. And it was a very difficult system, but it rapidly and instantaneously changed the world. It was responsible for creating the middle class. In fact, because they were able to pay the unheard of wage of $5 a day to the workers in that factory, the factory worker became the modal purchaser of the Model T Ford. It created the middle class. It created a market, in fact, for these products. And this quickly, and as I mentioned, rapidly transformed the world. It's still in use today. If you could not compete with mass assembly production, you were quickly out of business. The problem is with scientific management that it fails in the face of increasing complexity. And think about healthcare as a complex organism. No wonder Taylorism, mass assembly line production, doesn't apply to us. So 1931 was the next intellectual breakthrough with a gentleman named Walter Shoehart. He was a mathematician and brought mathematic analysis to Taylor-style production. For Shoehart, it wasn't just the reliability that his techniques brought to the process, but the rate of change that this made possible. And it was utilized quite heavily in World War II. At the beginning of World War II, particularly in the Pacific Theater, the American forces were vastly outperformed by the Japanese Army, particularly in aviation. There's the Japanese Zero made by Mitsubishi, who could fly faster, turn sharper, and it truly controlled the skies. But using Shoehart's method, through the course of World War II and reliability in manufacturing, we ended up with a plane called the Lockheed P-38, and that turned the tide of the war, that and through other things. And at the end of World War II, using this, we abandoned really this method because the war was over, and two, we were the only economy of any size left standing, and it was easy to resort back to Taylor's principles. And so this really was our method one at Intermountain Healthcare for how we change practice. It was built on Shoehart, reliability and rate of change, and we started it with what we called QUE studies, or quality, utilization, and efficiency studies, where we used data and data reports for rapid learning in what was meant to be a judgment-free environment. It was to take the data and the mathematical analysis of the assembly line type processes that we were doing around a couple of care conditions, reporting them to clinicians and asking them, well, this is interesting, how do we improve the process? And using rapid cycle with this data to make changes. The problem with this, though, is that physician profiling is methodologically unsound, and there really are a limited number of care conditions because of statistical limitations to which this method could be applied. But it's something that we continue to use when appropriate, and has been very, very valuable for us in associating variability and improving on rate of change. Well, just before World War II, while Shoehart was writing his studies, a gentleman named Dr. Deming was growing up in my neck of the woods, Rock Springs, Wyoming. He came into contact with Dr. Shoehart in New York around Columbia University just before the war, and during the war, these two were really responsible in large measure for introducing these quality control concepts and writing about them for the manufacturing process to support the war effort. Well, some of these writings made it over to Japan. While we were succeeding, they were trying to succeed as well by making these rapid rates of change, and had come into contact with much of this writing. So by the time MacArthur was occupying Japan, the Japanese asked whether or not they could have access to Deming. It turned out he was traveling home from India, and so he started a long relationship with Japanese leaders and manufacturers that culminated in organizations like Honda, like Toyota, like the reorganized Panasonic, changing Japanese manufacturing from junk to a synonym for quality. And this is Deming's core theory. All productive activity happens through definable processes. All processes produce three categories of parallel outcomes: physical outcomes, in our parlance, medical or health outcomes, cost and service outcomes. These are principles on which you're all engaged. And the key to Deming's theory really is about the idea of variation. There is such a thing called common cause variation and special cause variation. Common cause variation is that which is related to the provider, in a sense. This is the negotiated implant price and delivery, the day and time of surgery, how we conduct MRSA surveillance, pre-op antibiotics, and VTE prophylaxis. Special cause variation is that which is brought by patient complexities or individual physician complexities, such as just how fast I can operate. And finding and identifying common cause versus special cause variation is the key. It leads to lean or pull-through production, exemplified by the Dell method, where you can go online here today and order perhaps a Dell computer, specify about a dozen to 2 dozen different parameters, and almost immediately that computer, through lean or pull-through production, it begins to be assembled in Austin, Texas, shipped to you within a week. This is the idea that we need to bring, at least, or that Intermountain Healthcare has brought to bear as method number 2. In relation to the complexity from healthcare, we can either subspecialize, and we certainly see enough of that, or we can mass customize, develop shared baselines that help manage and guide care. And it helps us overcome these great limitations that lead to the variation science that we know about. First of all, lack of valid clinical knowledge regarding what is the best treatment. There may be 20 to 30% of what we do has some evidentiary basis or good evidentiary basis in the literature. There's exponentially increasing new medical knowledge to the point where it's impossible for a clinician or a social scientist to keep up with this in any meaningful way. Continued reliance on subjective judgment when making decisions. It's dominated by anecdote and notoriously poor for making reasoned and consistent decisions. And the limitation of the expert mind lead to this craft of medicine, which leads to ideas like, if it might work, try it. Lawrence Weed described this about the thought process, and I think this is a lovely quote as well. Until now, we have believed that the best way to transmit knowledge from its source to its use in patient care is to first load the knowledge into human minds, and then expect those minds at great expense to apply the knowledge to those who need it. However, there are enormous voltage drops along the way for medical knowledge. The core assumption is that our minds are interpreters of evidence, that we take evidence, they're processed in our minds, we reach conclusions, and these actions are reasonable. Therefore, nobody has to tell us what to do, just give us the evidence, we'll figure it out. Besides, there are lots of other factors that are unique to me and unique to my patient. Nobody has to tell me what to do. This is the craft of medicine. But lots of other things affect our minds. This was illustrated, I think, well by Dr. Lamb's second case. That was a second case, a 67-year-old female with altered mental status and respiratory failure. What led Dr. Lamb to make the conclusion that this was stroke and aspiration pneumonia? A recent patient with stroke. He was working on the book, perhaps Headmaster's Wager at the time. Was it the probability theory to understand gaming theory that led him to say something like, well, it's just too improbable that a husband and a wife would both have lung cancer at the same time? Who knows? I make these cognitive leaps all the time in my practice, so I don't say this disparagingly, but it's just real. So many other factors affect us moment to moment that making consistent decisions at the right time in the right place are too difficult. And so the miracles are slipping through our hands. This poor evidence and the inherent complexity leads to all the factors that we mentioned, the huge variation in beliefs and the well-documented massive variation in practices. And so we came up with practice protocols or shared baseline, recognizing that the evidence is poor, that medical opinion is essentially random, that guidelines don't often guide our practice, and that most guidelines have no validation data. And so this is the technique that Intermountain Healthcare has followed. We select a high priority process. We try to generate an evidence-based guideline. This is the work that you're all doing in your hospitals and your efforts, regardless of whether it's clinical or support or social or with communities or patient-centered values. And we try to blend that guideline into our flow of clinical work. Use the guideline as a baseline with clinicians free to vary on individual patient needs and to learn from that over time. The setting really is critical. as you get clinicians together to discuss. Use real cases, not abstract discussions. As we developed our ventilator protocol, it was about each individual patient and where the protocol was successful and where it fell apart. And therefore, you can only make a couple of different choices. Decide the protocol is wrong, decide it's right, or decide whatever happened was just random noise and move on. Remember, as you work with this with your clinicians, that no protocol fits every patient, and no protocol perfectly fits any patient. And for us in Intermountain Healthcare, therefore, it's more important that we do it the same than we do it right. Now, that's not to say that we don't try to do it right. This first evidence-based best practice guideline essentially is an attempt to do the best we can, but we always add the caveat, we know it's not perfect. Let's start with this, let's learn from it, and let's see where it takes us. It gives us a chance to apply the PDSA cycle and really the scientific method to improve as we go. And we have the rules that we won't tell our clinicians how to practice medicine, but we will argue the science. If we can't convince them based on the science, then we don't have a business in that particular realm. But we'll try to create an environment of professional accountability where professionals, physicians and others, can work together in similar settings to manage towards these problems. Now, the method 3 that we use is about technology and decision support. It's more than we have time to discuss this morning, but we use it to drive shared baselines, to drive communication, and to drive innovation for clinicians, patients, and families. This cartoon where the patient says to the doctor, "I'm sorry, doctor, but again, I have to disagree," holding a trove of internet resources. Traditional quality assurance looks like this. It focuses on the tail, and it assumes that if we somehow eliminate the tail, that what remains is good. It has asked falsely, historically, am I good enough? Can I hide under the threshold, instead of saying, am I the best that I can be? We need to move towards this idea using Shoehearts and Deming's method of true quality improvement, where the mean is moved and the bandwidth or the standard deviation is narrowed. It makes the outliers announce themselves, whether that's the process outlier or the professional outlier, but it makes it quite clear. And we need to move towards a place where the healing professions return to our core fundamental values. QI theory and practice, as I've told the narrative, truly has been housed in business and manufacturing, but it should have grown up in medicine. Its relationship to our values, its relationship to our mission, make these a beautiful match. We need to get back to putting our patients first, and so much work here in the United States is ongoing on this, recognizing that there is this special body of knowledge, that we have been given a fiduciary trust, and that's more than just money, a true fiduciary trust to promote and honor the health of our patients, and that we police our ranks in a way that promotes true professional autonomy versus personal autonomy. And as we sit here as leaders and as administrators, we need to recognize that much of what we do is out of our hands. Recognize and assume that your frontline clinicians, wherever they work, are as smart as you are, as dedicated as you are, as hardworking as you are, and are as motivated as you are. They're the only ones truly with the fundamental knowledge to know how to change the system. So your job is to set up the system and an environment under which they can work, to make sure that the barriers are removed, that the opportunities for learning and collaboration are there. And only then can we expect these very busy frontline clinicians to be able to contribute in a way that we describe as 100% participation, where we say to them explicitly, 95% of your job is to do your job. 5% of your job is to help us help you do your job better. Classic learning all the time. Make it easy for them to do what's right. And so here are our 5 axioms of healthcare, really, our axioms of healthcare at Intermountain, that most treatments for a specific condition have similar characteristics. There still is massive variation in clinician practices, and that truly all of us in this room and all of our clinician teams, provider teams from across our 22 hospitals and clinics, have something to learn and something to teach. We will lead most of the changes ourselves, given the proper environment that is set to drive change forward. And the clinical integration, or to embody these principles, really is our strategic plan as we go forward in the next 5 to 10 years, as healthcare will evolve and change and competition will evolve and change in the United States. And so I'll end, really, as I began, with this quote from Dr. Osler. But this time, put it in our present day context, as we talked about yesterday in the sepsis discussion. I am sorry for you, young men and women of this generation, or of the generation that follows us. You will do great things. You will have great victories, and standing on our shoulders, you will see far. But you can never have our sensations, to have lived through the revolution, to have seen the birth of a new science, a dispensation of new health, reorganized medical schools, remodeled hospitals, a new outlook for humanity is not given to every generation. I submit to you that upon our retirements at our version of the Phipps Clinic, we too will say this: we are at that moment in time where we will reorganize medicine, we will reorganize hospitals in ways that are fundamental. Now, at our retirement, at our version of the Phipps Clinic, we will be wrong too, just as Dr. Osler was wrong. But take this moment in time as a challenge and as an opportunity, and recognize that you're here in this room for that very purpose, to return with one or two ideas that change healthcare fundamentally, and that cumulatively across the province, or across Intermountain Healthcare, or across North America, these add up to great and powerful things. The broad topics we've talked about today, the foundation really is in this room and in this course as I've looked at the syllabus. A terrific opportunity to learn the nuts and the bolts, the bricks and the mortar, the wiring of how this house is framed and built. Congratulations on being here. Thank you again for the invitation and for all the work that you're doing. Thank you.